And we can actually give this to somebody accidentally from putting in a chest tube. Okay, so those are some of the things that you need to watch for. Any questions so far? Positioning for lobectomy and pneumonectomy. Okay, the positioning for pneumonectomy for a lobectomy. You're talking about post-operatively, right? So post-operatively, you're going to have chest tubes. With a lobectomy, you can position on the side that has not been operated on. So if you got a right lobe taken out, you can turn him onto the left side. Okay? But don't turn him onto the right side. This is the lobectomy. With the pneumonectomy, that means taking a whole entire lung out. Okay, post-operatively, you want to lay him on the same side that you took the lung out. Okay? The same side. So the operative side. Now, I use words like operative and unoperative side on purpose. And why do I do that? Because those are the words you're going to see in NCLEX. Okay, if I don't use them, you don't know them, and I'm talking Greek to you. Okay, so you've got to know what these words mean. So there's a reason for my speaking the way I speak, in other words. Okay, let's talk about urinary tract infections. Some predisposing factors for UTIs. Number one is urinary stasis. So what does that tell you? That tells you if you gotta go, you gotta go. Okay? So how many of us work as nurses? We come in the morning, we don't get breakfast, right? And then we go. We feel around about 9 o'clock that we gotta go, but we don't have time to go because we got all these meds that we have to pass, so we forget it. We don't go to the bathroom. We continue to pass the meds. Then all of a sudden you don't have the urge to go anymore, and around about 12 o'clock when you finally do get to go to the bathroom, Lake Erie is what you produce. Okay, one of the Great Lakes. So you just, that's urinary stasis, folks. You cannot do that to yourself. If you got to go, you got to go. It takes, 2 minutes to go to the bathroom? It takes 2 minutes to go to the bathroom. So go to the bathroom. Indwelling catheters are another predisposing factor. Decreased body resistance. So all these old people who live in nursing homes, do you think they have decreased body resistance? And how many of them have indwelling catheters? A lot. Okay, and how many of them are well hydrated? Oh, maybe 2. So you're talking about a problem here. Increased estrogen levels also can predispose you. So if you're on HRTs or birth control pills, that will predispose you to urinary tract infections as well. So difficulty urinating or dysuria, okay, frequency, urgency, certainly, nocturia because you're up all night peeing, yes. A fever, usually a lower grade fever with a UTI. With urinary tract infection, it's usually about 100, 100.4. Very seldom will it get much higher than that. You'll have suprapubic, which is right here, right above the pubic area, suprapubic or low back pain. Okay, and you feel, oh my gosh, you feel like a little old lady. Well, some of the diagnostic tests, obviously, is we'd get a UA, we do a culture and sensitivity, and we know that the culture and sensitivity is basically to find out what bug or what organism is causing the UTI and what antibiotic will work to fix it, right? Some of the other interventions that we can give them are what? Amoxicillin, Cipro, okay? We'll give fluoroquinolones, which is Levaquin, Tequin. We'll give Bactrim. We'll give Floxin, certainly. We also want to tell the patient that she's going to have to drink more than 3,000 cc's per day of water, preferably. Okay, certainly cranberry juice is a good idea, but water is a wonderful thing. It flushes your whole system out. We want to tell them to avoid caffeine and alcohol because actually caffeine is a diuretic and alcohol is actually a dehydrating agent. And it can cause diuresis as well. Do you know that for every beer that you drink, you need to replace it with 2 glasses of water? And that for every shot of hard liquor that you drink, you need to replace that with a full glass of water? Yep, because that's how much it takes out of your system. You want to avoid stagnation. In other words, tell them if they have the urge to go, they need to go. Don't hold it, okay? Acidify the urine. We talked about cranberry juice. And give vitamin C because vitamin C actually does help acidify the urine. One of the other drugs that we do give them is something called pyridium. And we know that pyridium does what? It turns your pee orange. So what I generally tell my patients is if you're wearing white underwear, try not to wear that while you're on peridium because you're going to have these little orange spots all over your underwear, and they're the devil to take care of. It's hard to take, yeah, really. Okay, so she's come in, she had a UTI, and now we've fixed her. All right, let's talk about pyelo. Hopefully we will not let the UTI progress to pyelonephritis. Multiple UTIs can actually be a predisposing risk factor for bladder cancer as well. But UTIs that are not taken care of can march up the ureters and actually cause pyelonephritis. And pyelo is an inflammation of the renal pelvis, and it's actually an infection in the renal pelvis itself. What you've got are little pockets. Yeah, see? See, we didn't take care of her real well, so now here she is. You've got these little pus pockets that are sitting in the renal pelvis. So she's got what we call CVA tenderness, which is costovertebral angle tenderness. Okay, these are your ribs or your costal area, and this is your spine or your vertebral area. So the tenderness lies between the costovertebral angle right there. Okay, so essentially what we do is we tap them on the back right at that particular spot. Now, if they've got pyelo, which is what we call the positive chandelier sign, yeah, because we tap it, they jump up and catch the that's how much pain it, yeah, you guys. Anyway, that's how much pain she's in. She jumps up to the ceiling and catches onto the chandelier. She has back pain severely, fever, and the fever will go up to 102, 103, 104 even. Very high. Chills, malaise, those sorts of things happen with pyelo. So what we've got to do is we've got to fix her. So we've got to monitor BUN creatinine. We've got to do isonos. We will give aminoglycosides. Now, it's at this point that gentamicin comes into play because now it's a big-time thing. So it's IV antibiotics now, okay? We may give Bactrim as well, but generally we give gentamicin. We give urinary antiseptics, like pyridium. We'll give antispasmodics like probanthine or baclofen. Obviously, we'll treat the fever. And the nausea and vomiting that occurs primarily because of the pain. Okay, not because of GI upset, but because of the pain. The pain levels are so high. So we got to fix her. Okay? Now, stones can occur to both men and women, renal calculi. And renal calculi are made up of different things. Okay? With renal calculi, you will find nausea and vomiting and severe pain. But again, the nausea and vomiting doesn't occur because of the GI upset. It occurs because of the pain. And the pain is in the flank area, and they always say it travels, right? The pain starts here, it moves all the way down to my groin. Well, a lot of that has to do with referred or radiating pain, or because the stone is actually travel in and of itself. And the majority of the time, they think that the stone is like a boulder, when it's not. It's about the size of a poppy seed. Okay? Hematuria is another symptomology. I mean, they've got blood in their urine, and that blood in their urine really comes from the stone just rubbing against the ureter or rubbing against the renal pelvis itself. So some of your diagnostic tests include a KUB, which is basically an X-ray. KUB stands for kidneys, ureter, bladder. Some places they call it the abdominal series. Okay? An IVP or intravenous pyelogram, they'll do a UA as well. What are your nursing interventions? Well, you're going to be pushing fluids. Essentially, if somebody comes into the ER with a kidney stone, we start an IV and we hang a liter, usually of saline, and we just run it wide open. We want to get him well hydrated because we want him to pee. Okay? Of course, that is not what he wants to hear because every time he pees, it hurts. But that's the only way we can get the stone out. Okay? We'll strain the urine. We'll give him, we'll give him Toradol, and Toradol works like a charm. It's an anti-inflammatory, okay, and it belongs to the NSAID category, the non-steroidal anti-inflammatory category. It works very, very, very well, and it just takes the pain away very nicely. And we will also give him a little strainer, and we'll say to him, if you have to pee, please pee through this little strainer, okay? Because we want to see if he's got any kind of, if he's past the stone at all, okay? Now, we'll give pain relief. We'll give antiemetics like Phenergan because he's nauseous. We'll tell him to modify his diet. Okay, and what do we mean by modifying his diet? Well, if he's taking a lot of calcium, I mean, if he's drinking a lot of milk and eating a lot of cheese, he might need to change it. Okay? And we will give Xyloprim, and if you give Xyloprim, you've got to make sure that you tell him he has to take a lot of water, a lot of fluid with it. That's an NCLEX question on Xyloprim, by the way. Okay? Diet management depends on the kind of stones. We essentially tell him to avoid milk and milk products and tea, because tea is very, very high in oxalate. Most stones are calcium oxalate, so you avoid milk and milk products, you avoid tea, and yes, you avoid beer. So how many guys do you think comply? Thank you. Right. All right. Now, we've done the girl thing, and then we've done the girl and guy thing, and now let's do the guy thing alone. Okay, we're going to move on to the guy urine thing. With the guy urinary tract thing, is benign prostatic hypertrophy is what we want to cover more than anything else. The definition of benign BPH, or benign prostatic hypertrophy, is that the prostate enlarges and causes pressure on the urethral, the passageway, right? Because you know that the urethra comes underneath the perineal area, and the prostate is right, it surrounds the urethra, and if it enlarges, then it causes pressure, and it actually inhibits the passage of urine. Okay, so that's how BPH is formed. What happens with BPH is it's fixable. It's easily fixable. Yes, they do a TURP with it. Okay, he has frequency. He's got nocturia, he's got hesitancy and urinary retention as well. And now the diagnostic test that for the guy is not something that men really particularly like. Does he look like he's running away from something? Yeah, he is, because the big thing is we do a digital rectal exam. So we tell him, drop your drawers and bend over. They don't really like that. And then the doctor puts a finger right up his rectum and he massages to see he wants to feel the prostate. Okay? Now, a digital rectal exam has nothing to do with the passage of his stool. It has everything to do with the prostate and everything to do with the urinary tract system. There is an NCLEX question where, this guy is having a digital rectal exam, so which of the following should you ask him? And one of them was, have you taken a laxative? And number 2 was, when was your last bowel movement? And then the third one was, how is your urinary status? So that's your choice. Because the DRE is done to assess the prostate and is done to assess your urinary status, the man's urinary status, not his bowel movements. So DRE is number 1. We also do a urinalysis, and you will find increased alkalinity because his PSA will be elevated, okay, and his BUN and creatinine will also be elevated. Okay, so what do? Well, we do a cystoscopy, and guys don't like this one either, because the cystoscopy essentially is that we take a little scope, we put it up his penis, and we go all the way up to his bladder, and we take a look at the bladder. They really don't like this. It's very uncomfortable. Okay, but we got to do it because we have to see what's going on. So what are some of our interventions if somebody does have BPH? Well, we've got the conservative method, and the conservative method is that we give drugs. Okay, we love to give drugs. Hytrin we give. Now, if your patient is getting Hytrin, what you've got to tell him is that he must take the first dose of Hytrin at night. Okay? Just the first dose that he ever takes of Hytrin, he must take it at night, because there is a possibility of hypotension with this. And you don't want him to take it in the morning for him to get transient hypotension, fall down and hit his head on you. Okay? First dose of Hytrin, take at night. After that, he can take it anytime he wants. Okay. Proscar and Prazosin are 2 other medications, and a TURP, a transurethral prostatectomy, is a surgical intervention that we utilize. That's pretty common, and it really works very well, and it's really not that scary of a deal. Okay? Preoperatively, TURP, what we tell the guy is you need to, we'll give you stool softness. Okay, you've got to be NPO 6 to 8 hours before. We're going to give you Ancef, which is an antibiotic also beforehand, and we're going to draw some blood work and get some urine samples and stuff like that, just the normal stuff. Post-operatively, this is where the nursing challenge comes in, because yes, you'll continue to give the stool softeners and strain the urine, and you're going to tell them no heavy lifting or straining, so no Valsalva.